Hello everyone, I am Dr. Tawab, co-chair of ISPRM Communications Committee, and today I have with me Dr. Fary Khan, who has just delivered an amazing lecture on cancer rehabilitation, now or never. So Professor Khan, would you tell us that why is it important right now for PRM specialists all around the world to start taking cancer rehabilitation seriously?
Thank you, Tawab. So everyone, it's a huge privilege to have given the Ollie Ook lecture today for the ISPRM meeting in Sydney. The reason I wanted to focus on cancer care was, as you know, whether anywhere in the world, the developed world and the developing world, low and middle income countries, the national health priority is focusing on cancer care along with dementia and aged care and so forth. So cancer care is a priority worldwide, which means governments are spending resources, allocating funds to build up cancer care. And it's not just about surgical care or oncology or radiation oncology, but it's about survivorship issues. Because the whole aim of cancer care is to make sure that persons with cancer will survive their cancer because of good acute medical and surgical care, and then will go on to live as a survivor in the community. But as patients finish their treatments, and even before, they need to be as fit as they can for surgery, for example, which we call rehabilitation, and that is basically the realm of the rehab medicine physician, because they can go in and support the allied health therapists and nurses, along with acute surgeons and oncologists, anesthetists, to build up the patient resilience for surgery so that the patient has the best chance of survival. So that's one. When the person has their surgery or their oncological chemotherapy, radiation oncology, the next step is post-chemo radiation oncology phase, where rehab medicine has so much to offer in terms of disability list addressing those issues, whether it is pain following surgical incisions or chronic pain because of neuropathies, or whether they have bladder and bowel metastases affecting bladder and bowel function, and how we can address, for example, lymphedema, for instance, or lung resections or sarcomas with limb amputations. So for every sort of patient who's had cancer treatment, there will be a survivorship issue related to mobility, related to function, ADLs, for instance, and reintegration back in terms of participation back to the normal role. So the role of rehab is massive across the spectrum of care, where from the time of diagnosis and rehabilitation all the way through the post-treatment phase, and then the longer-term phase in the community, which is probably the longest phase in the cancer care survivor's lifetime. It is the most expensive and the most difficult phase because it's an ongoing longitudinal follow-up. Currently, with various cancer programs across the world, the post-discharge into community phase is very poorly addressed. Patients will go back to see their surgeons and oncologists, and they'll have targeted treatment only regarding the acute medical and surgical management, but not the various disabilities that I mentioned. And therefore, having rehab physicians involved in that phase in the community for best outcomes in terms of function and reintegration is where we need to focus. So I hope that my lecture today will inspire a lot of the youngsters all across the world. It's not about money and resources. We can only do what we can do with our workforce, with our health systems, with the support given by our health departments, and with the support of the WHO and the resolution on the WHA for strengthening health systems within rehabilitation. I think that's so relevant. And I hope that maybe this is a little bit of a guidance for some of you who may be interested and able to implement those strategies to provide best care for our patients. Thank you.
So you are the pioneer of actually the cancer rehab program in Australia. So for those PRM specialists out there who are just about to start their journey, so what will be your message for them regarding the key, for example, components that they should focus on at the very beginning, so as they are able to start the cancer rehab program in their own country?
Thank you. So I don't think I'm the pioneer of cancer rehabilitation. That's very kind of you. But I have had some fantastic teachers, mentors, like Professor Andrew Cole, for example, who was the chair of Hammond Health in Sydney, and he did a lot of cancer work. And I found his work very inspiring, and I tried to take a lead from him. And I guess that's what my advice is, that all the younger rehab medicine physicians who are interested in this area, firstly find a mentor, find out what needs to be done, what has already being done, and then build gently as able within resources, within time, within the monies involved, within the workforce, as to how you can go further. But I think advocacy is first. So unless you realize there's a problem and you raise that issue to people who are higher up, so that some action can be taken from top down, but also the bottoms up approach.
Yeah.
It's a combined approach. And I think guidance and getting help, and with the ISPRM, we have the education committee, we have the communications committee, we have the international exchange committee. So we have so many resources that we can, utilize and learn and share our findings and collaborate with colleagues and move forward. It's not a one-man show.
Exactly.
It's a team effort.
Yeah. Yes. Thank you so much, Dr. Fary, for giving us your time.
Thank you, Tawab.